But as Dr. Sharma was telling this morning, this conferences like this size are not possible without the support from our from the companies we have who really support us a lot during these time, especially when they bring in some new products which are beneficial for the patients and which are game changers in CLI, CLTI management and endovascular therapy. So Abbott is doing this, and it's thank you so much, Abbott team. Really appreciate it. So we are going to talk today about the newest product they have, which has really changed the destination therapy for the CLTI management, especially and infrapopliteal vessels, which has been an Achilles heel for us in the treatment of these vessels. So let's go for it. And their newest system is the Esprit system, which is a drug-eluting resorbable stents, so we call it DRS. DRS, so it's scaffolds. So I can never pronounce the resorbable scaffolds. So, all right. So I think you guys know me. So BTK. So below knee therapy for PAD has always been a big Achilles heel because of the lot of reasons. Because the vessel size is small. The anatomy varies all the time for patients. The lesion lengths are much longer, even though they mimic coronary vessels, but they have much longer lesion lengths, and the calcification is very severe, especially in patients with dialysis and CKD patients and diabetic patients and chronic smokers. So traditionally, the therapy was the plain balloon angioplasty, which started initially, which has, as everybody knows, has a patency rate of about 35 to 40%, which is not great. That's when the specialty balloons came into play, and the DCBs are not doing very well in infrapopliteal vessels, at least as of now. Future might change. Atherectomies and PTS came into play, which have a patency rate again of about 56 to 60%. Then IVLs are taking a great role in this calcifications. We had coronary stents, drug-eluting stents, which worked very well in BTK. There are a lot of trials which have been Yukon BTK, Achilles BTK, which have done very well in below knee therapy. And Esprit, because they had scaffolding, and now Esprit has a scaffold, which has changed the shape, actually destination therapy for below knee vessels, because it not only gives a drug which inhibits neointimal hyperplasia, but also gives you prevention against the recoil, and it leaves nothing behind, which is what we usually want, so that we have future therapy options for these patients. So I'll just go over the system, how the scaffold looks like, and then I'll give the database to Dr. Rao to present it. So it's just a scaffold. The resorbable scaffold is a backbone which is made of polylactide. I'll tell you how this PLLA works. It's coated with everolimus, and it's one of the only everolimus stents we use other than the drug-eluting stents we have in the market for coronary systems, for peripherals. It's very hard to see. The biggest difficulty is the visibility, which makes sense because it's just a scaffold. It's not a metal platform. So you have two platinum markers, two on the proximal end, two on the distal end, which will show you during these presentations in some cases how can they be visible. And over time goes, I think it becomes more difficult to see them. And placement of the balloon and how the markers is, Dr. Rao will go over it in a case. So they have a new system. They initially came up with an RX system, a monorail system. Now they have over-the-wire system, which is the newest Esprit BTK. It gives you more trackability because now they have more. You can put it over the wire and can go much more down and have more pushability through the system, which is great. So it's 5 French compatible. So if anybody does pedal cases, it works for them. And if you do it, in generally CLI cases, you should not be putting sheets in the system, in the pedal vessels. That's our way of doing it in Mount Sinai. But again, there are other people, operators who do from pedals. So they vary from length. They go from 2.5 to 3.75. I think the 3.75 can go up to like 3.82 or 3.9. And it goes from 18 to 38 lengths. So they have 3 lengths, all 8s, 18, 28, and 38. So And we will go over how to predilate, how to prep the vessel and everything when we go over the cases. So the radial strength is great. It's pretty much comparable to any other coronary stent which is in the market, or probably even better. But over time, again, the radial strength. But again, you need that radial strength in that first 6 months or first 3 months of the recall, which is where the scaffold gives you the strength to resist the recoil. And then after 6 months, once the endothelialization happens, technically you don't need the stent platform for the recoil, which is what serves it. So the stent, I'll just go over very quickly about how the stent looks. The stent, once it's implanted, the elution happens for 3 months, just like any other coronary stent, which is great, which is suppresses all the neointimal hyperplasia. The struts, this is how they look like. They are not evenly placed. They are unevenly placed on the vessel wall. Once they go into the intima and media, they are like polygonal structures. They are like square structures in the first 6 months. So these resorption, the degradation of these stent struts is incredible how they are made. That's why I said the PLLA platform, it's a polylactide platform. So whenever it's like a mixture of, whenever there's water, like the vessel has blood and the water seeps into the tissues from the vessel, and this water mixes with the lactic acid, which is on the PLLA platform, and basically melts the platforms away and over time degrades the struts. And the struts, this is how the strut structure looks at 12 months. So you have pretty much the struts stay open until like 12 months. You have that platform for 12 months. From 24 months, you can see the degradation starts. At 36 months, pretty much it becomes a part of the new intima, and then 42 months, you completely don't see the stent at all. The biggest advantage is you lose the mass of the stent, and now this area where the scaffold is placed becomes really good even for future purposes. Like if the patient fails any other destination and you want to do a bypass, you still have a chance to do a bypass onto the lesion exactly you put the scaffold. So Dr. Rao is a surgeon, vascular surgeon. He's going to say his perspective of how he looks at this stent, but I think it works great. Dr. Rao? So Dr. Rao is the associate professor of vascular surgery here, and he's the director of the vascular surgery research program in Mount Sinai.
All right. Thank you, Dr. Gujja, for that kind introduction. And thank you to the entire Abbott team, New York EVS, for the opportunity to present. So really what I want to focus on is the data for the SPREE, and then we're going to spend some time talking about cases. So the LIFE BTK randomized control trial is really what we're going to spend a lot of time talking about. But even before that came out, there was some data looking at bioabsorbable stents below the knee. So this was the Absorb BTK trial. It enrolled patients from 2013 to 2018. And what they found was pretty promising results. So this was a prospective, non-randomized trial, but they found at 5 years a 72% primary patency rate, 90.7% freedom from TLR. And so based on this data, obviously these are very promising results for below-the-knee disease. This was subsequently followed by the LIFE BTK trial. So this was a randomized control trial, I believe from 2023. It randomized 261 patients, and it compared the bioabsorbable SPREE stent to balloon angioplasty. And so this is really, in my opinion, a landmark trial. For below-the-knee disease, really a couple years ago, most of us were just doing balloon angioplasty, plus or minus atherectomy, but it was really based on non-randomized data. And this was the first trial to show something that works better than just POBA. So this, we now have data out to 2 years. And just going through the trial, so the inclusion criteria, it was any patients that had infrapopliteal disease, specifically in the proximal 2/3 of their tibial arteries. Obviously, you don't want to put a scaffold, a stent near the ankle area, near the joint area with all that flexion that could, disrupt the stent. These were patients that had vessel diameters 2.5 to 4 millimeters, which goes along with the sizing of the stent. And these were Rutherford 4 and 5 patients. This was really an international study, although most of the patients were enrolled from the US. As you imagine, these patients are vascular patients, so they have all the typical comorbidities that you imagine: hypertension, hyperlipidemia, diabetics, dialysis. most were Rutherford 4 or 5. That was all that was included in the trial. So really the typical patient you'd see in your clinic. In terms of the baseline characteristics, so all patients were treated, all tibials, so PT, 18, perineal, and in somewhat of an equal distribution. They did include calcified lesions, so most of the patients ended up being mild or moderate calcium, but those weren't necessarily excluded. And then the lesion length was around 40 millimeters on average. So the primary endpoint for this study was limb salvage and primary patency. That was initially followed out at 1 year, and I'll present the 2-year data as well. The control, as we know, is POBA. They also measured the safety, so to make sure there was no major adverse limb events or any mortality out at 30 days. And so, again, this was the first randomized trial for the below knee space to really show a significant difference. So the primary endpoint, the SPRE, was 74.5% versus 43.7% for PTA. So that's a 30.8% absolute risk reduction, which was, of course, significant. They didn't find any safety concerns either with using a drug below the knee, as some of the other prior trials had suggested. And then we now have more recently the 2-year data, which shows this sustained effect. So at 2 years, the ESPRI did 61.5 for the primary efficacy of limb salvage and primary patency versus 32% for PTA. And again, I think these results are pretty, remarkable because, when I think about tibial lesions and kind of these patients, they frequently come back because you're just ballooning them 6 months, a year later, they're coming back. But in this case, you have something that suggests it works better than POBA. And this was clinically significant as well. So 90.3% of these patients out at 2 years didn't require reintervention. So I think this is very promising data, and I think as we get more real-world data, that will kind of support the efficacy of using bioabsorbable scaffolds below the knee. But really what I want to spend a lot of time on is just talking about cases. And for this, I really kind of want to have a conversation with Dr. Gujja, if he doesn't mind, just to discuss how he would approach these cases. So this is the first case in mind. So this is a 75-year-old male, typical comorbidities, hypertension, diabetes, on dialysis. He came through the emergency room with a right foot ulcer. Typically, if I see them in the office, I'll get an ultrasound or ABI, but in the emergency room, oftentimes we'll just get a CAT scan just because of the, availability of vascular lab at our hospital. So the CTA, is representative of the angiogram, which is here. So everything in the SFA popliteal was fine, but then as soon as you get to the tibials, you can see very significant disease. So the anterior tibial tapers out, the perineal also tapers out, and it looks like you may have a good posterior tibial. As you follow that down, you can see it looks pretty healthy. But the challenge with this patient was the posterior tibial artery below the ankle really tapers out and does nothing. And then you can see what looks like a dorsalis pedis that comes back in the foot that may be a little more robust than that posterior tibial. So maybe I'll stop here. Dr. Gujja, when you looking at these films, kind of how would you approach it? Like what vessels would you consider targeting, and what are you thinking in terms of your intervention?
Yeah, we usually go by angiosome theory. At least I do it that way. So I always go to the vessel. Direct revascularization is what I prefer. So here, anterior tibial looks like the dorsalis pedis is forming out. I think reconstituting from below, probably from the diseased posterior tibial. You can't even say the posterior tibial is enough because even though it's reconstituting the dorsalis pedis, it has distal disease. So I think revascularization, the AT as a first attempt is, especially with the dorsal wound, that's the territory which is supplied, I think will be probably the right thing to do. I'm assuming that's what you did.
Yeah, thankfully that is. So we targeted the anterior tibial. Number one, it's better in the foot. Number two, that's the angiosome. So angiosomes, right, are where the tibial, what it feeds in the foot. So in this case, it was a dorsal foot wound. So it made more sense to go after the anterior tibial. And then I think when you're thinking about interventions, just like when we do bypasses, you always want to think about inflow, outflow, and then your conduit. So in this case, the inflow is fine, but the outflow, I think is much better in the dorsalis pedis than the posterior tibial in the foot. So then, we targeted the anterior tibial, and I guess you can see the completions here, but I think one important thing with this spree is how to prep the vessel. And then maybe I'll get your input too, but I think you definitely have to prep the vessel, in my opinion. I think you really want to maximize your drug delivery and maximize the chance of the scaffold expanding. So you can't just go in straight with the scaffold, and it might also not track that well if you haven't pre-dilated it. So I think you need to at least balloon angioplasty it, if not considering some sort of atherectomy device. My algorithm for this is if there's a lot of calcium in the vessel, I'll choose to do some sort of atherectomy. Orbital atherectomy, I think, works very well in certain cases. And so this patient did have a good amount of calcium. It's a diabetic dialysis patient. So I chose to pre-dilate, use orbital atherectomy, the 125 micro. I like to IVUS for these cases as well, and I think with the spree it's especially important. I think we have a tendency to undersize sometimes, or worse, oversize and rupture the vessel. So I'll always IVUS to know exactly how to pre-dilate, what balloons to use, and what stent size. So on IVUS, I think it was around a 3.5. So I ended up using a 3.5 angioplasty PTA to pre-dilate, and then I used 2 scaffolds, kind of in the proximal mid area where it was the worst, to open this up. And you can see got a good result, much better perfusion, I think, through this dorsalis pedis down to the foot. But I guess I'll open up to you. In terms of prepping the vessel, would you do anything different in this case, or how do you approach it?
It looks great. One thing about Dr. Rao is he always gets the case done, 100%. So the thing is, when you first see the pictures, the initial pictures when it was underfilled, I think even after PTA, that's why IVUS becomes important. Normally I would have probably used just a 3.035 balloon and thought it's a 3.5 vessel. But the IVUS is what tells you exactly, this is very important. This is a scaffold. There is no metal platform here. So you really want a good apposition of the stent. That's why you have to pre-dilate it very well. And that's what Dr. Rao did. And he used a little larger size stent so that the scaffolds are nicely embedded into the media and intima. So you really want a good apposition of these stents for a good result. And I think it's a phenomenal result. I think 100%. I almost 100% of the times, I always IVUS before putting Esprees in.
Yeah, that was my question. Are you routinely IVUSing for
Always.
Yeah. I think, to be honest, a couple years ago I wasn't, but now, especially with sizing of the scaffold, I think it really helps, because I've had a couple cases where I thought it was like a 3 vessel and it turns out to be a 3.5, 4 vessel, and I would have undersized the stent. So I definitely think IVUS is very useful. And then I guess the other question for you is, when you have these long segment CTOs, I struggle a little bit because, I'd love to put in, I'm sure, Abbott would too, would love to put in like 5 scaffolds, all the way down. But realistically, depending on where you can't really, you have to think about cost too. And so hopefully they'll come out with longer scaffolds, and this won't be a discussion down the road. But in terms of having a long CTO, how would you approach managing that? Where are you going to put those scaffolds, or how do you decide?
I usually put it at the proximal cap. I mean, that's the normal way to see it, because that's where you start your the CTO from. But again, the IVUS will tell you where the most recoil is. And usually, I haven't put more than 2 scaffolds in a patient. I think what you did was good, and it looks phenomenal. I think you put it exactly where it's supposed to be. But from the economic standpoint, I think Barbara is probably better off to take this question. If you put more than 2 scaffolds, how does it work? What do you think, Barbara?
Is this on?
Yeah, we can hear you.
So we say that the most common answer is reimbursement is it depends. It depends on the site of service, if it's an inpatient or an outpatient, and appreciate that a lot of these are outpatients. And then secondly, going to the outpatient side, right now the difference in the hospital-based outpatient payment for an APC with a balloon angioplasty alone, that runs for 2025 around $11,000 on a national level. The payment for the APC, when you include the 2 scaffolds, runs at about $17,000 to $18,000. So there is room in there in the difference between the APC payments today for the difference between balloon angioplasty and likely up to 2 scaffolds.
Yeah.
Dr. Rao, how many do you choose? Like, you choose based on wherever the vessel recoils, or?
Yeah, I think you got to balance a couple of factors, but obviously you want to do the right thing for the patient. So if you need, that many scaffolds to fully treat it, so you don't leave residual disease. I think that's fine. On average, though, I would say for a long segment CTO or a long segment disease that I'm treating, I'll probably use around 2 to 3 scaffolds, and I think that usually will get the main area. That being said, now that it's been a year or two since we've done some Esprits, I've had some of these patients actually come back, and I'm actually seeing some of the disease recurrence not at the site of the scaffold, but just proximal or distal. So I do think in an ideal world you would be able to scaffold it after you treat, for many of these patients anyway. So yeah, this patient did well, healed their wound, and I think I put them on dual antiplatelet therapy, which is kind of my standard regimen for a lot of these patients. So this is another case that I did. This is a 65-year-old male presenting with hypertension, diabetes, and a left foot non-healing ulcer. As a surgeon, I always like to think about, the option of bypass, which you should, and you should know the best CLI and kind of the data for that. But one of the main things is whether the patient has vein or not, and this patient did not have vein. I actually did an angiogram on this patient, I think 6 months before they came back in, and I'll show you kind of what we found on these films. But you can see here the popliteal artery, the below-knee popliteal artery occludes, and you can maybe see a wisp of an anterior tibial here, and then maybe it comes back here. But basically everything that I fixed with a POBA and a DCB in the popliteal had kind of come back. And then further down below, you can see the anterior tibial reconstitutes, and it's a pretty robust anterior tibial all the way down, and it's one vessel run off to the foot. So in this case, I think it's, you don't have many choices on what you can treat. You need to treat the popliteal into the anterior tibial. But I think this is a challenging case because you're dealing with a occlusion, a disease that happens right at the popliteal artery into the tibial artery. And so you have to deal with the sizing, right? So popliteal artery on average can be around 4 to 6 millimeters. And then you're talking about a 2 to 3 millimeter vessel. And kind of treating that junction point, you have to do carefully. So maybe I'll stop here. Dr. Gujja, how would you kind of approach this in terms of how to cross, how to intervene? What would be your algorithm?
I think complex disease, right? Especially if it re-stenosed, that means all recall and atherosclerotic vessel. I think this is a great case, Dr. to show why Esprit becomes important, and why metal platforms can create an issue. I mean, here, of course, popliteal has to be treated because it's an inflow vessel, and once you get into the AT, it's not much of a choice. You have to get into the AT because that's the dominant vessel of the foot. I think, I would probably just get into the AT, atherectomize the POP, probably DCB the POP, and then probably Esprit the anterior tibial. I don't know what you did.
Yeah, I think because we work at the same institution, we have similar approaches here. But that's what I essentially did. So I think just kind of talking about it a little bit, I think, in my opinion, atherectomy is very useful here because you can debulk the lesion. This is not a gray area to stent in the popliteal going into a tibial junction. You can if you have to, but I think if you can really debulk it and avoid a stent right at that junction, that can help, especially with that bend there in the anterior tibial. So my approach would be atherectomy, and then after that, again, IVUS to get the sizing of the vessel, see what balloons you need to predilate. For the popliteal, after the atherectomy, I'd probably use a drug-coated balloon. I think that's a great option here. It's a recurrent disease. There's some intimal hyperplasia in there, I'm sure. So having drug on there after I prep the vessel will help. And then for the anterior tibial, same thing. It's kind of challenging because it's a long segment, right? It's the origin of the anterior tibial all the way down to almost the mid segment. So for that, I'm going to take a long balloon, just pre-dilate it. And then if I see any spots that really have recoiled or look the worst, I'll probably center the scaffolds around there. If I don't see that, then I might go by my initial angiogram and see where it looked the worst and center it there, right? Because sometimes you can actually get a good result. You do the POBA after, you cross the lesion and the tibial looks pretty good. But if you believe in the data and the drug and the scaffold, then you should still put a scaffold somewhere in there to improve your long-term patency. If it's a good candidate for a scaffold. So in this case, I did orbital atherectomy. After that, again, IVUS. The popliteal artery was about 4 millimeters, so I used a 4 millimeter drug-coated balloon. And then I think I saw on IVUS, and I think another good reason with IVUS is if you look at this angio, honestly, the anterior tibial to me doesn't look too bad, but there was some residual stenosis that you can see on IVUS. IVUS always looks worse than an angiogram, almost always. And so we ended up putting in a 3 Esprit. For the trial, I think they, avoided it by the ankle, of course, which, I think you should. And then also very proximally in the AT. That being said, I put the scaffolds near the origin of the AT, even with that bend, and I haven't had any issues with it. So that's what we did here. And then we post-dilated it with a 3 balloon based on the IVUS and, got a good result here. And this patient's now, I think over 6 months, this was done over 6 months ago and still patent on the last duplex. All right.
Yeah,
Okay.
Ajit, actually, I have a question for you. So in this case, as a surgeon, when you're putting it in, it's one vessel, right? If the patient recalls, I know it's a non-usable, like you don't have a vein to use, but let's say the patient keeps failing and you have to use a PTFE graft. Does putting an Esprit help you, like in future, be a target for your bypass? Would you put a bypass exactly in the place where you did the Esprit?
Yeah, I think that's a good question. I think it makes it easier. So, for example, if I saw this diagnostic angiogram for the distal target, I'd probably avoid the area of disease here, and I'd probably sew somewhere down here where it's a little healthier. But that being said, you don't always have that choice, and so if there was an Esprit there, it would be a little easier to kind of, I've had to do that once to kind of endorectomize it and remove it. So, and the fact that it's also bioabsorbable means that if I have to do that bypass, 3 years from now, then in theory, there should be nothing there to prevent me from sewing onto it. So I think it's better than putting in like a coronary stent, which is off-label anyway. So yeah, I would choose bioabsorbable.
And also, when you stent across another vessel, like tibial vessels, getting into, let's say there's a peroneal I see on the back. I don't know how dominant, it looks like it's not that dominant of a vessel, but let's say you have a dominant peroneal and you want to get into the peroneal, getting across the stent struts. Does it make you easy other than a metal platform? Does Esprit give you an edge over it?
Over like a coronary stent?
Over a coronary stent, because you have to get through a metal platform. I mean, we do it in coronaries all the time, but again, there is a recall in the stent, so it's not.
Yeah. Yeah, I mean, I think ideally you would try not to stent near the origin of the vessel, but if you have to, obviously you have cases like that. I think, yeah, in theory, a Esprit would be easier to kind of track things through than a metal scaffold. And again, it's, after 6 months, it kind of you start to see kind of the breakdown, the resorption, so it's going to be easier to cross those lesions again. So yeah, no, I think that's an important point. All right, I'll turn it back over to you.
So I was told, real world case, because I not only do cases in the hospital, but also do it in the OBL. So I'm probably one of the first OBLs in the country to use Esprit. Don't ask me how I do it. The cost effectiveness, I think Barbara will go over it. I don't want to get into the detail. I think you guys have to talk to your reps and see where it's necessary. I can only tell you why is necessary in the OBL sometimes. So I have an 88-year-old patient with hypertension, dyslipidemia, and prior PAD. Patient with a great toe ulcer. So basically Rutherford class 3 and 5. Dr. Krishnan is going to go through the CLTI classifications after the breakout sessions, so you guys will know about that. Has been on medical therapy and wound care. The ABI is on the right is 0.3, so basically comes under the critical category. And right leg arterial Doppler shows total occlusion of the pop and the infrapop vessels. So this is the angiogram. You can see it's a disease vessel diffusely, but mainly just like Dr. Rao's case, it's like a mid-pop, like in the just above the P3 segment, it's occluded, and it reconstitutes basically through the collaterals into the AT as well as the peroneal. The AT does form, but AT kind of tapers off and becomes a disease vessel. The peroneal seems to be the dominant vessel of the foot, which forms the dorsalis pedis down in the foot and the PT. There is some disease PT which comes off here, but again tapers down into a very small vessel. So I felt like wherever my wire takes it, I'll take the targets, the AT or the peroneal, but my target was to do the peroneal because that's the dominant vessel of the foot. So I was able to get into the peroneal as I really wanted to. And I tried to be as luminal as possible. And then I did the atherectomy of the POP and the DCB after that. But I would say, and I'll tell you what I did, and I think Dr. Ram might do it a little bit differently, so I want to take his opinion. Then I did just atherectomy and PTA of the tibioperoneal and the peroneal artery. And this is the result after that. Ajit, would you do anything different? Would you go into the 80 or would you still choose the peroneal?
No, I think I would have done something very similar. Number one, I think if the perineal artery is the dominant runoff, then that's definitely the one to target. Also, logistically, I feel like sometimes it's easier just to cross because it's a straight shot down versus trying to get into an AT or PT. So your wire will often preferentially do that if you keep the wire straight. So yeah, no, I would definitely target the PT, and then I agree. I think atherectomy here would be a decent option because you can debulk it and maybe minimize the amount of stents you need to put in here, and definitely need drug. I think that's been shown to be very helpful, especially in this area. So yeah, I think I would have done something very similar.
So this is the post-atherectomy DCB and PTA result. So I mean, for me it looked okay. There is some recall in the proximal end, but as I said, this is the only vessel going down to the foot, so I wanted to protect the peroneal. The plan was to stent. What kind of stent I wanted to decide based on how the IVUS looks. And how the origin of my AT comes off. I felt like my origin of AT is somewhere here. So I felt like I still have a future option to do the AT. So I was it. So it looks like, at least based on the angiography, most of the vessel looks similar, just like Dr. Rao said. The AT looked fine, but there's one area of recall. So I felt like this is the area of that recall, this is my distal cap. But if you see the IVUS, it will show you how deceiving the angiogram can be. So the whole peroneal, from the proximal peroneal into the TP trunk, is all like significantly recalled. There is some calcium, a lot of fibrosis. The IVUS catheter is like snugly fitting in to the whole vessel. So we measure it. It looks like it's an 89% stenosis. The MLA came to 1.33, so the vessel diameter is 3.5. So basically, we have about 90% recall in the vessel after the atherectomy and prolonged PTA. I usually PTA for at least 3 minutes, just to get a better result, but it looks like I have a significant recall in that whole peroneal, not just one focal spot. So based on that, I felt like if this is the recall, the next step is to stent the peroneal. But I did not want to lose the option of getting back into the AT. So I did not want to put a metal platform. And also the other thing is I didn't want to take away the option of bypass. If I have to send the patient to Dr. Rao and if it recalls and fails, I didn't want to take away the option of bypass for the patient. So I put an Esprit into the peroneal and the tibioperoneal trunk, right to the origin of the anterior tibial right here. So you can see the small dots of the proximal and the distal end of the Esprit. So this is the final result of the Esprit. You can see the small dots. They are not very visible, but you see them initially once you place the stent, the proximal and the distal markers. So I put a 3.5/38. I pre-dilated it with a 3.5, and then I put a 3.5/38, and I post-dilated it with a 3.75 balloon. And I think that's all I could get because I knew that the vessel diameter was only 3.5. So this is, and then patient was not healing the wound completely. I didn't see much of an improvement, so I felt like I should go for the anterior tibial also to give more support into the foot. So this is angiography 4 weeks later. It looks like the DCB worked very well in the POP. The remodeling, the reason I wanted to show this was I wanted to see show you how the Esprit remodeled just in 4 weeks. You can see the Esprit here and even magnified view, and you can see them here. You can already start seeing the Esprit kind of push out the vessel and give you that radial strength. So I'll show you how the ultrasound looks, how the struts look on the ultrasound also. So I went after the AT. I opened up the whole AT into the foot. So now we have 2 vessel runoff for the patient. And you can see one marker of the Esprit up here and another marker down here. So it still was a little visible. And this is the post-ultrasound images about a month later, 4 weeks later. I always do ultrasound of the patients who I put Esprit a month later, just to have data for myself. So this is how the struts look. They look more like calcified, but they are not as ultrasound opaque as they're supposed to be. They're not like calcified chunks or metal platforms. They don't cause shadowing on the ultrasound like calcium. So that's how you can identify it. They don't. So you can clearly see, like normally if there's calcium or the stent, you can see an ultrasound shadowing, but that's not how they are. They're very lucent. So you can measure it nicely. So my stent size was exactly, the technicians are trained to perform it, so they know exactly to see the stent size, to see if anything happened to the stent studs. So it looks like from the proximal stud to the distal stud is 3.79, which is 3.8, which is 38, which I thought. And the vessel looks like it's 3.57, 3.6, which is exactly what I wanted it to be. So it looks like there is no recoil throughout the stent studs. And I always do color flow and the velocities just to check and see. I do it 1 month, 6 months, and 12 months. That's normally what I do, just to keep the data for myself. And this is before the intervention, and this is 14 weeks later. The patient completely healed the wound, and I think we did what we got to do. Dr. Rao, anything else would have done differently?
No, I think that's a great result. But I think one point you mentioned is important, is that you can post-dilate the Esprit, especially at this junction point. You know, if you're going from the popliteal into the TP trunk, there might be a little taper point, and so you can take it up by 0.5 centimeter and really size it 1-to-1, which I think you did really nicely there. But yeah, that's a great result.
Yeah, so now I felt like even if the AT recoils, after like a year or 2 years, because CLI patients have a very high rate of recurrence, so if he recurs with the wound and with the peroneal recoils, Dr. Rao still has a target vessel to go for, the proximal peroneal. So I would like to invite Barbara to come over, talk about coding and reimbursement, which is very important, especially when it comes to putting multiple stents, multiple scaffolds. We need to understand in the institution how it works. Thank you so much.
So I was thinking to myself on the way over here, what's more challenging than talking to a group of surgeons about coding and reimbursement? And it's talking to a group of surgeons about coding and reimbursement right after lunch. So thank you so much for allowing me to do this. We added this section to our sessions just because there are a lot of questions that come up, particularly as we deal with new technologies. And it's important, I view our role from a health economics and reimbursement perspective to enable you to do what you do best for our patients. And that's all about access, and particularly in this environment that we're living in today in the United States, access means a couple of things. It's coding and coverage and payment. And so I'm going to present to you the highlights of all three of those things here related to Esprit specifically as a brand new breakthrough technology that is, as you can see from the results from these cases, really adding beneficial it's a technology and a therapy that's really important to the CLTI patient group. Okay, so I said before, it depends. Every site of service in the United States has a little bit different reimbursement. Hospital inpatient is categorized by what's called MSDRGs, or major diagnostic groupings. That's a combination of both the procedures themselves as well as the characteristics of the patients, the comorbidities and morbidities associated with the patients. A hospital outpatient is, again, categorized by groupings. This is similar procedures based on similarities of cost. And so within the endovascular procedures, there's 4 categories, essentially, that all of the procedures that you'll do will fall into one of these 4 APC or ambulatory payment classifications. Ambulatory surgery is like the stepchild to the hospital outpatient department. It runs very much in a similar fashion, with the idea that costs would be a little bit less in an ambulatory surgery center because it's very focused. You have less legacy overhead, and as a result, you have just a very more efficient kind of procedural aspect of determining what the overall cost structure looks like. And then in the office-based lab, well, nobody ever envisioned, I think, when they created our physician reimbursement system, that we would be doing these types of procedures in office-based labs. So that actually gets divided into two pieces. The vast majority of the physician payments that go through our physician payment system in the United States are based on the work that you do, the professional services, the complexity and the time and effort involved in taking care of the specific types of procedures. But then there's the office-based lab category, which they consider to be non-facility, meaning that it's not done in a hospital outpatient, or an ASC setting, and so it's done in the physician office lab, and that is unique in the sense that they have the entire payment is captured in that payment rate for the OBL, both the physician work component and professional services, as well as all of the overhead devices, supplies, and equipment that would be involved in taking care of the patient there. So this is kind of at a very high level, the current payment for our inpatient and outpatient hospital procedures. You can see on the left-hand side, there's kind of three major categories of inpatient procedures. The first is involved in what is called other vascular procedures. It's a pretty broad category that includes lots of different types of vascular procedures. And the range in payments from 252 to 254 are based on whether or not they have any complications and comorbidities, a few complications and comorbidities, or major complications and comorbidities. Then the other part that is unique here is we have, if you are using atherectomy as the calcification modification approach, it falls into a different category. Again, it's a combination of algorithms that are based on both the procedures as well as the patient characteristics. But if you add atherectomy as a patient procedure, that moves it into the 270 to 272 MSDRG category. And then thirdly, if you add IVL as that approach that you're using to modify the patient, you're now then moving into a separate category where they've just bucketed into two because there's not quite as many procedures in that categories yet at this point in time. On the outpatient side, as we talked about or briefly in the question that came up earlier, the straight POBA for below the knee lands in the 5193 APC, or what we call a level 3, which the payment rate is around $11,000 on a national basis. Obviously, if you're in a higher wage area in different geographic areas across the United States, that fluctuates a little bit. Upper East Coast, New York is obviously a higher wage category, so it'll be a little bit higher than that. Some places in the country like Louisiana, Alabama tend to be a bit lower, but on average, the rate is $11,000. If you do a spree scaffolding, you fall into that next level of APC, which is the 5194 or the level 4 payment, and that includes things like atherectomy. It includes IVL, but it also includes a spree. So the difference between doing plain POBA versus doing an spree in a procedure is a roughly $6,000 spread. Again, can vary a little bit across the country, but that's in general what's going on from a APC perspective right now. We just received approval from CMS for what's called a new technology add-on payment. This is inpatient only. It applies to Medicare, traditional fee-for-service. It starts October 1st of this year. And what it is a program that Medicare put in place to try to offset some of the incremental costs of new important technologies that have breakthrough status in particular. So in order to qualify for an NTAP, it has to be new. It has to show substantial clinical improvement, which I think the results from LIFE-PTK substantiate that piece. And then it also has to cost a little bit more than what you would typically find in the system. And there's some calculations that we go through to come up with that. So basically, a spree qualified. CMS approved it for us. They set the cap for the NTAP, which is an incremental payment that the hospital gets on top of the DRG payment. to offset up to 65% of the device cost. So they set that cap based on a $10,650 device cost overall, considering that there are lots of longer, on average, lesion lengths that occur in the tibial peroneals. So the most important thing for your hospitals as you go out into practice is that there are very specific, unique ICD-10 PCS codes or ICD-10 procedure codes that are for Esprit. That's part of the process. We had to apply for them and get them approved. Those are what will trigger the calculations for NTAP. So make sure that your coders are capturing the fact that when you're using Esprit in a hospital inpatient basis, that they need to use these new technology codes specific to Esprit in order to trigger the NTAP analysis that will occur. This I kind of covered. We suggested to CMS that based on a whole number of publications that were out there, that the average lengths of lesions ranged from 41 to 244 millimeters with a calculated weighted average of 135.1. So that's what we requested that they set the NTAP cap based on, and that's what they went ahead and did. On the ASC side, again, it's kind of the stepchild of the hospital outpatient. There we're looking at the specific CPT codes or procedure codes that the AMA sets up. We had a really unique situation with Esprit as a brand new technology. Even though there was a CPT code for 37230, which is the stenting and angioplasty in the tibial peroneal, there has never been an FDA-approved device until Esprit to fit that specific procedure code. So it was a little bit unique. We didn't have to go in and ask for a new CPT code because there was one that fit the exact procedure. At the same time, it was the first FDA-approved one, and so the data, usually CMS takes a look at historical data and then they decide what the payment rates are going forward based on that historical cost data. The historical cost data was a bit referenced on the fact that there was this approach to only stent if there was an absolute bailout or an absolute necessity, and only when one, if at all possible. And so as we try to change that paradigm from just a clinical practice perspective to enable multiple scaffolds within the lesions, and that, we're continuing to work on ways to improve the hospital outpatient side of the payment rates as well. And there's a couple of things that we have in play right now that hopefully at some point I'll be able to report back to you in the not too distant future. So on the physician side, what you see under the facility column, that's basically the work value that you get as a physician. You probably have heard of RVUs, relative value units. For those of you that are employed by hospitals, those might come into play in determining your overall compensation and incentives. For the non-facility piece, that is basically those procedures that are done in the physician office. And so the reason that they're so much higher than what you get on the facility side is because they do include all of the overhead, all of the devices and supplies and equipment, and that takes into account when you're doing that type of a procedure in a physician office that's off-site. Coverage. Now, it used to be that we didn't really have to talk that much about coverage because most of what we did was, or what you did was really, something that was fairly routinely covered. Medicare has gotten, Medicare Advantage in particular, has gotten much more strict about what types of things they'll cover. And basically what coverage means is like the payers, whichever payer it is, decides whether or not they consider this procedure to be medically necessary for this particular patient. Medicare in general, Medicare fee-for-service, has had broad coverage for the most part for all of these endovascular procedures. Medicare Advantage and commercial plans have started to get very specific in their policy language around what gets covered, how it gets covered, where it gets covered, and what types of things you need to document in order to demonstrate that this procedure that you're doing for the patient is medically necessary. And they have what's called prior authorization, which everybody's heard of now, and everybody kind of cringes because you have to go and pre-approve or prior authorize a procedure as being medically necessary before the insurance company will agree to pay for it. So again, we are working on with the societies to try to overturn some of the less than optimal coverage policies that have come into play over the last couple of years, and we've been successful at that. For Esprit itself, we have not run into any coverage issues. And so, lots of times when you have a brand new technology, especially a breakthrough technology, payers will slap, oh, it's experimental and investigational and we're not going to cover or pay for it. We have not encountered that yet with Esprit, I think in particular because we have an existing code that has been in place for almost 15 years now. So prior authorization is likely going to be required for your Medicare Advantage patients as well as commercial patients, but again, these procedures are being covered by payers and at the rates that we talked about. So. One other thing, we have lots of resources. If you have questions, want to get into more detail, obviously in 10 minutes or less, I'm not going to kind of spew out all of the things there is to know about reimbursement, but I also don't want to keep you from your next event here. And so, feel free to contact any of us at Abbott in our Reimbursement Services Support Center. We have field reimbursement people. We have a lot of information available on our website. And if you have questions as your hospital starts to implement NTAP or anything coming up here, we're happy to help you and work with your coding and reimbursement folks to sort through that. So I'll take any questions.